We have already seen how acute inflammation occurs in our body. Now we move on to chronic inflammation. Today we are going to look at its pathophysiology, cell mediators, T-cell mechanisms, morphological appearance, and a short overview about granuloma. We will study granuloma in detail in our next video.
Chronic inflammation is a prolonged condition. It can last for weeks or even months. It is driven by three distinct events. These events happen at the exact same time. First, we have active inflammation. Second, we have ongoing tissue injury. And third, the body is simultaneously attempting to repair that injury. The pathology unfolds all at once. Blood vessels transport platelets and white blood cells directly into the tissue. These white blood cells are called leukocytes. Inside the tissue, we see areas of dead tissue known as necrosis. This dead tissue is surrounded by immune cells called neutrophils. Right alongside this destruction, the body attempts to repair itself. It uses epithelial cells and fibroblasts. Fibroblasts are specialized cells that build new connective tissue. This process leads to collagen deposition. It also leads to angiogenesis, which is the formation of brand new capillary blood vessels. When we look at the pathology in prolonged state, we are establishing the baseline mechanisms. To understand this condition, we have to see how a brief reaction shifts into something much longer. There is a stark contrast between a rapid, acute reaction and a prolonged, chronic state. An acute state acts quickly. A chronic state is different. It is a slow burn. It leads to continuous tissue destruction. Let's compare the two. An acute state has a rapid onset and a short duration. A chronic state persists for weeks or months. It sometimes arises silently from an unresolved acute response. Acute inflammation brings vascular changes and swelling. Chronic inflammation recruits a mononuclear cellular infiltrate. This means specialized cells, like macrophages and lymphocytes, arrive to stay. This shift is highly destructive. Acute reactions cause minimal damage and eventually resolve. Chronic inflammation causes severe tissue damage. Unresolved triggers and hallmarks are responsible for sustaining the reaction. For this condition to last, it requires instigators. These triggers act as the continuous engine of the disease. There are three core categories of unresolved triggers. These are what sustain the inflammatory engine. They are persistent infections, hypersensitivity diseases, and prolonged toxic exposure. Let's break these down. Persistent infections include evasive viruses, fungi, or parasites. They also include mycobacteria, like tuberculosis. These trigger a delayed immune reaction. Next are hypersensitivity diseases. These involve excessive, inappropriate immune activation. We see this in autoimmune diseases, like rheumatoid arthritis, or allergic diseases like asthma. Finally, we have prolonged toxic exposure. This involves agents the body simply cannot degrade. These can come from outside, like inhaling silica dust, which scars the lungs, or they can come from inside, like excess cholesterol driving atherosclerosis in our arteries. The physical evidence of these triggers leaves unmistakable hallmarks. Mononuclear cells heavily infiltrate and crowd the tissue. These include macrophages, lymphocytes, and plasma cells. Their relentless presence causes severe structural destruction. This damage is driven by both the offending agents and the inflammatory cells themselves. Concurrently, the body frantically attempts healing. It tries to replace the damaged areas with new blood vessel tubes and thick connective tissue fibers.
Granulomas and macrophage activation provide containment and control. Sometimes the body encounters difficult agents that cannot be easily cleared. When this happens, it attempts a radical strategy of physical containment.
The body creates a highly structured exclusion zone. We call this a granuloma. It has an outer layer of encapsulating T lymphocytes. This layer acts as a barrier. It surrounds an inner cluster of activated epithelioid macrophages. At the very center of this ring, there is sometimes a zone of completely dead cells. This is called caseous necrosis. We commonly see this specific pattern in infections like tuberculosis. Macrophages are the true dominant force in most chronic reactions. They function as professional phagocytes. This means they are cells designed to eat and clear away debris and microbes. But they are also the master orchestrators. They dictate both tissue damage and healing. They do this by choosing between two distinct activation pathways. The first path is M1, or classical activation. M1 is destructive. It kills microbes. It secretes chemical signals like TNF and IL-1. These signals drive continued inflammation and tissue damage. The second path is M2, or alternative activation. M2 promotes repair. It secretes a different signal called TGF-beta. This drives fibrosis and the building of new blood. The supporting cellular ensemble brings in specialized secondary responders. While macrophages orchestrate the response, they do not work alone. Other specialized cells are recruited to fuel the prolonged reaction.
Eosinophils respond to parasitic infections and allergies. They deploy a highly toxic protein that kills parasites. Unfortunately, this also causes severe collateral damage to the host's own tissues. Mast cells are widely distributed in our connective tissues. They release mediators like histamine. This bridges the gap between acute and chronic reactions. Finally, we have neutrophils. Normally, these are the very first responders to a brief injury. But in an anomaly, they can persist for months in specific chronic environments. We see this in ongoing lung damage from smoking.
T-cell subsets and amplification are responsible for cementing the chronic state. The sustained inflammatory engine is driven by a bidirectional amplification loop. The macrophage and the T-cell enter into a constant dialogue. It is an unbreakable communication loop.
The cycle works exactly like this. The macrophage presents antigens to the T-cells. It then secretes a signal called IL-12. The T-cell receives the signal and activates. In turn, the T-cell produces its own cytokines. These cytokines then recruit and activate even more macrophages. The cycle feeds itself continuously. It guarantees that neither cell type ever stands down.
When those activated T-cells produce cytokines, they don't all send the exact same message. The T-cells branch into 3 distinct subsets. Each subset routes specialized chemical signals to specific cellular targets. The first subset is the Th1 cell. It secretes a signal that triggers the classical M1 activation of macrophages. This gives them enhanced microbicidal power. The second subset is the Th2 cell. It secretes a different combination of signals. These recruit those toxic eosinophils and trigger the alternative M2 tissue repair pathway. The third subset is the Th17 cell. It secretes IL-17 to continuously recruit fresh neutrophils and monocytes to the site of inflammation.
These signals culminate in 2 massive systemic pathways. The systemic amplification path is driven by TNF and IL-1. This promotes extensive cell adhesion and triggers body-wide inflammatory effects. At the same time, the fibrotic matrix path is driven by TGF-beta. This is the body's most potent stimulus for collagen synthesis.
Ultimately, this is the integrated engine of chronic inflammation. Unresolved triggers constantly pour into the endless communication loop between macrophages and T-cells. This results in a continuous, unyielding collision. Severe tissue destruction happens on one side, aggressive fibrotic repair and new blood vessel formation happen on the exact same tissue at the exact same time.